Hey, happy Monday afternoon. Dr. Alan Christensen here with you, and welcome to Office Hours Live. So, this is a special day. Yeah, I'm seeing people jump on already. Welcome, welcome. Good to see you all. So, this is the second day of International Thyroid Awareness Week. Did you guys know that? Yeah, good to be with you all. So, quick recap, we're on YouTube Live, on Facebook Live, on Instagram Live, and this is Office Hours. So, I've got a few things set to cover, and I'll grab a couple of your live questions. And come on and say hi. Some of you are already. Good to see you. And hey, Michelle. Hi, Jean. Several others coming on as well. Always love to hear where you are, how you're doing these days. And if there's some top questions, we'll cover a few of those too. So I'm going to drop a link here right off the bat. And this is, here we go. Okay. That's going to show up now for those who are seeing on Facebook and YouTube. I'm going to get this visible on the Instagram world too. Shiriham, many others coming on. Yeah, good to see you. Hey, Lana, how you doing? Good to see you here. So this is International Thyroid Awareness Week, and this is a brand new thing. This is now the 14th year in which we've had World Thyroid Awareness Day, and that's coming up on May 25th. But another group has made an overlapping event, which is International Thyroid Awareness Week. And this is kind of funny. This is May 22nd through May 28th. So it's a 6-day week. I'm not sure how that worked, but it's a 6-day week. I double checked those dates. So we have Thyroid Awareness Month, which is January. And then we have World Thyroid Day, which is coming up on May 25th. And now we have International Thyroid Awareness Week. So this is a big thing. You know, there's two sides to this increased awareness. One of which is there's more people that have thyroid disease. So that's problematic. The plus is that there's more recognition of it being a relevant thing and being a real driver of symptoms. A link I just put up, this is this tinyurl.com World Thyroid Day. I'm doing an event on the 25th. This is a free event on Zoom. And this is going to be, towards the idea of really recovering from thyroid disease, like really recovering and getting better. One of the first steps is pulling together a team that can help you do that well. And that's something I hear a lot is like, who do I find in my area? Who do I need to have collaborate with me? Do I want this kind of person, that kind of practitioner? What is it? And so this one's all going to be about building your recovery team. And yeah, this will be live on World Thyroid Day. This will be taking place. Let me triple check before I say the wrong time. It's on the link does say the time, but this is on May 25th. And this will be 6 p.m. Pacific or 3 p.m. Eastern, and World Thyroid Day. So coming up on this coming Wednesday. So really big day. So the link is up there. I'm going to put that, it's in the chat, and that should be visible there for, those on Facebook and YouTube. And we'll get the link up for the Instagram right away too. So hang tight for that. Okay, so one other topic I wanted to mention real quick was about AIP. I've had a lot of questions about that over the years, and someone just sent in one asking about the use of various types of starches on AIP. Yep, someone just put the time up there. Thank you for that. Okay, so here, I'm going to clear that out and go on now to the images. Here we go. Okay. Hey, Kelly, right back at you. So here's the logo for World Thyroid Day, our event coming up. And yeah, the link is there. You're welcome to sign up, join us live on Zoom, and talk about building your team for full recovery. Now, here was a question that came in. Dear Dr. C, my nutritionist said that purified starch without anti-nutrients, like your shake, is okay. And in the shake and the RS Complete are okay on my AIP diet. What other starches can I use? So this is a fascinating question. So the AIP diet, autoimmune paleo, if you hadn't heard, and the basic idea behind it is that autoimmune disease is thought to be driven or worsened or aggravated by irritating factors from the diet. So a lot of common allergens and things that may be possible irritants are eliminated from the diet for the period of time. And many of those are carbohydrate residues. Now, there's not so much a clear one holy grail list. There's a lot of common themes about the AIP diets, but some argue that purified starches are okay. And apparently this person's nutritionist is one who said that as well. So what's the difference there? Well, so the concern is that some starches contain anti-nutrients, and the AIP tries to avoid phytates, oxalates, lectins, things along those lines. And this nutritionist is one that has recognized that some food extracts do not have those allergenic ingredients. They simply have them eliminated. Some have argued that cornstarch, potato starch are fine. And so this one told her that the ones that we've used in our products are okay. And that's true. So we use a purified pea starch extract in the Daily Reset Shake, and the RS Complete is all food extracts that either the food itself is AIP or the non-AIP ingredients are taken out. Now, again, I want to state this. There are different interpretations on what is or is not AIP, and there are some that would say otherwise about various starches. So I can't speak for all AIP advisors or practitioners. But there are those who argue that these things are okay. And I wanted to share something really fascinating. A big difference about AIP diets is that they are often low iodine diets. So I'm seeing a lot of you guys just coming on. I'm going to zigzag back and forth just slightly. I've got to tell you all again, for those who just came on, that we've got a really big event coming up, and that is World Thyroid Day. So boom, there we go. World Thyroid Day, May 25th. I'll put this back up in the chat. This is a link you can join us. This is a free event that's taking place on this coming Wednesday. This will be 6 p.m. Pacific, 9 p.m. Eastern. And this is going to be about really building your team for full recovery. I believe that recovery is possible. And for many, that can mean their thyroid works again completely to a large degree. It definitely means the symptoms can get better. But a really big stumbling block is having the right people in your corner. And a question I hear a lot is, how do I find someone in my area? What kind of practitioners do I work with? How do I go about these various steps? And how do I pull my team together? So this is going to be about assembling your team for recovery. And that's World Thyroid Day. Okay. So I'll come back now to the discussion on AIP, but before then, I'm seeing a lot of really good questions come in, you guys, and I'm going to grab on a couple of those. So if you're here with me live on Instagram, on YouTube, or on Facebook, feel free to type your question in, and I'm seeing many pop up in our chat. And I'll grab a couple of those. I try to get ones that'll be the most representative of other questions. So I'm seeing one pop up right now that's timely about the event. The event will be recorded. So yes, I'll have that, and we'll get those recordings out available afterward. But if you want to come on, you'll hear it live and get to participate as well. So yes, the questions, I'll grab a few of those, and I like to get thematic questions, so ones that allow us to talk deeper and deeper about a particular topic. I've really come to think that it's easy to find lots of just facts and figures online, but it's hard to get context. It's hard to get nuance. And that's why I love to do these and talk to you guys live, because we can really make it be more applicable for you and, not just rattle a bunch of stuff off. Someone said, someone I did a consult with the other day was saying how she tallied up the books, articles, podcasts, the things that I've done. And it was a lot. She had this list of how many things there were. And it would be so not as worthwhile to just have that big stack of stuff. It's there, but it's so helpful to get it like when things are personalized for you. So that's what we're doing here. So yeah. And I'm seeing some good questions. I'm eager to start diving into these, but really quickly, I'm going to talk more about that question that came in about the starches, about AIP. So quickly, I want to mention about the relevance of iodine to AIP. I think this is really important. So this was a assay of the iodine content of what could be a very common meal in America. And it was funny. I did some Google searches on most popular American breakfast, and this is based upon some rather large surveys. Most popular American lunch, dinner, snacks, and so on. And these are the foods that came up for those particular popular meals. And then I took some detailed analysis about iodine content of these exact foods, and using the exact brands whenever possible. So what you see is that those who are on Facebook and YouTube, there's a graph here. It's a table. And the bottom line of it is that you could easily top in at over 500 micrograms of iodine on a daily American diet. Somewhere between about 50 to 200 micrograms is a safe range for someone prone to get thyroid disease. If someone has thyroid disease and they wish to improve upon it, they can go under 100 micrograms for their best response. And that's what I talked about in the Thyroid Reset Diet. I shared a lot of studies showing that thyroid disease can reverse between about 60 and 80% of the time, like more often than not, with just that one approach. But yes, a standard diet can be well above that. So the use of iodized salt, that can be 140 micrograms right there. So a breakfast of eggs, bagel, milk, orange juice, this was roughly what, 100, 200, a little over 200 micrograms right there at breakfast. That's the whole day's target, just from the one meal before using salt or anything else. And then a common lunch, just a typical lunch sandwich. This ended up being the bread, the cheese, not so much in the ham, but they had some clam chowder that showed up with this. This was another several hundred micrograms. The dinner wasn't as high, but the snack, that was surprising. So you can get 60 micrograms of iodine in a common candy bar. So this day's total ended up being 581 micrograms. Now, I've tried so hard to find, what is it that we know about diet that can make a difference for thyroid disease? And there's literally a handful of studies on a few odds and ends, and that's it. And then we've got tens of thousands of studies about what iodine can do and how powerful it can be to change that. So I think that's a real big common thread. So if that's what a standard American diet can commonly have, then what about like a AIP diet? Well, I went through some real popular AIP menus and pulled together what they would end up producing for a day. Now, most of those use sea salt. There's a really big range of iodine in sea salt, but it's easy to get a fair amount. So there was about 50 micrograms in a low volume of sea salt with the AIP diet. Now, this AIP diets, the menus that I came across, the more popular ones, had ground beef and cabbage for breakfast, and that ended up being just a few micrograms, barely any at all. Then lunch had about like 10 or 20 or so, and then barely any for dinner. So lunch was bacon, basil, leaf lettuce, olive oil, small amount of smoked salmon. Dinner was ground turkey, duck fat, olive oil, and carrots. And altogether, pretty much all that came from the sea salt, believe it or not. The total day's intake was only 66 micrograms. So I really think in a lot of ways that the AIP diets help because they end up being lower iodine diets. Many don't realize that going into it, but they end up greatly lowering the iodine intake for people. And I think to the extent to which they're useful, that's probably why. So a lot of really good questions. I'm seeing some that are relevant to what I was just saying moments ago. Let me jump on those first. So here's one, Farm Meets Table. Why, if there is so much iodine in our diet, why do some get thyroid issues and others do not? Yeah. So great question. So there can be a lot in the diet. Now, there have been some really detailed surveys that look at the iodine per subgroups. And I'm not saying everyone's getting way too much. That wouldn't be accurate. But somewhere around 30 to 40% of people in America are getting well above 200 micrograms per day. There's strong evidence about that. So with iodine, we have to think about our requirement for it, like the minimal amount we need to be healthy, and then our tolerance for it. They're different ideas. We may require a certain amount, and then we can tolerate a certain amount. And the tolerance means how much we can have above our requirement before it gives us any problems. And those who are not prone to thyroid disease can very short term probably tolerate about 1,000 micrograms a day. The World Health Organization argued probably like 1,100 to be precise. So that's the upper end of tolerance. But here's the big but, those prone to thyroid disease, their tolerance is probably more like about 200 micrograms per day. It's not as high, so they can easily get above that. So that's why some really get these issues and some don't, because some just have a better tolerance for iodine than others do. And we think that this variation exists because humans had very different amounts of iodine exposure in the distant past. A large number of humans were living in coastal areas, and in those cases, food from the ocean directly, and also food that was grown in soils near the ocean, was the bulk of their diet. And they had to be able to eliminate extra iodine when they got more than they needed. So there's some deiodinase genes that make people very good at dumping extra iodine. Now, there were also many humans that lived in areas that were not coastal. So we look at those who were in the mountainous areas, in the Andes, the European Alps, also near the Himalayas. And these are areas that are far removed from ocean influence. There's no real seafood in the diet, and the soils themselves are not directly exposed to seawater. They're not close to it. And some of these areas, kind of interestingly enough, iodine does evaporate into the air from the oceans and it does rain down. So some areas that are inland still have abundant iodine in the soil, but others do not based upon their rainfall patterns. And so in those areas, people had to have different genetics that were good at holding on to every bit of iodine. The trade-off is they weren't as good at getting rid of the extra. So it's largely those genetics that do well in low iodine environments. Those are the gene variations that make people more prone to thyroid disease. And that's why not everyone gets it, but some people do. They simply have a different tolerance of that. Now, there are some actual genes I can talk about and I've written about, like in the Thyroid Reset Diet, I talked about certain known RS numbers you can look up. But gene status means very little compared to gene expression. So it's really not whether you have a gene, it's whether that gene is acting in a way that's causing problems. And the way you know that is if you're prone to thyroid disease. So if you have developed abnormal thyroid labs, you are someone who is not tolerant to those mega doses of iodine. If your thyroid's always been fine, especially if you've had a lot of iodine in various forms, it's probably not a factor for you. But we don't know if that stays the case. Personally, I don't have thyroid disease. I have used seaweed in higher amounts in the past. I got lucky, but I don't push it. I know that my luck may run out, and I don't want to have that happen. All right. So many good questions. Here's a quick, easy one. What day of a menstrual cycle is best to test on? I'm on the pill and having irregular cycles. So if you are on the pill having irregular cycles, the easiest time then is during your period itself. You know when that will be. That's going to be usually more predictable. But the other way to think about that is doing that during the blank days of your pill. If you've got some blank pills that don't have active hormone, those are good times to test. So yeah, if you're on oral contraceptives, best to test during those times where you're on the empty blank pills. So related question, Nutrifoal was recommended for hormonal hair loss, but has 225 micrograms of iodine per day. What is the impact of this on my hypothyroidism? Well, it's not good. Yeah, if you're prone to thyroid disease, a safe upper limit from all days sources, from supplements, from cosmetics, from medications, from foods, your better upper limit from all day sources to break even, not to get better, but just to not make things worse, is about 200 micrograms per day. So you're above that. Now, the other wrinkle about iodine in supplements is that they don't have what they say they have. There have been a couple of big assays in which they have just simply bought supplements that have a labeled amount of iodine. Then they analyze those in laboratories to see how much iodine is actually there. And it's never what's on the label, like not even close. In many cases, it's 3 or 4 times greater. But even if it was correct, that's already too much. And this is the big thing, is so many people are taking supplements that are giving them too much iodine. And this is why thyroid disease does not get better. So here's a classic example of that. Vicky saying, took 12.00, I'm guessing, Vicky, you mean 12,000 micrograms or 12 milligrams of iodine, now have a nodule and up 30 kilos. Is this reversible? Please help. So Vicky, yeah, it often can be. It can take some time. Now, someone asked recently, how do they get rid of iodine if they've got a whole lot in their bodies? Well, it's just time. Well, I'm sorry, it's two things. So it's time, but then it's also having so little come in that you've got a chance to clear off the excess. And then the third thing is to make sure you're not overdosed on thyroid medication. So the only way your thyroid gets rid of iodine is by excreting thyroid hormone. OCD. Okay, that's not the only way, but it might as well be the only way. Your thyroid can squirt out some iodine that's not in hormone, but it's so darn little, it's almost negligible. So if you're on an excessive dose of thyroid hormone, your thyroid's making zilch, and so there's no iodine coming out, and so it just stays that way. If you're on a reasonable dose, that's not really a factor. You're still having some come out. So the trick is, Vicky, to have your current intake low enough. And by low enough, that's really below that 100 microgram per day target. I outline that in that reset phase of the thyroid reset diet. So basically, it's focusing on green light foods and making sure your cosmetics aren't giving you more along the way, or any other factors are as well. So here's so many good questions, you guys. I'm just picking and choosing and looking. So first off, I'm thinking about ones that are related to what we've covered. So here's one that's related to these. Patricia's saying, you recommended kosher salt instead of iodized salt, but what is the difference between sea salt, Mediterranean sea salt, and kosher salt? A lot of the organic items I buy say sea salt in the package. Are all brands of kosher equal? Yeah, so Patricia, take a peek at the Thyroid Reset Diet. I did a whole detailed discussion on salt. The short answer is there are some brands of sea salt that have been assayed and are consistently low in iodine, and many that either have not been assayed or have and have very high levels or inconsistent levels. So any product, you just want to see third-party analysis. I've only found consistent, reputable, recurrent third-party analysis on two different products, and I did talk about those in the book. So when salt is in products, take a look at the total amount of salt you're receiving. The idea of only using kosher salt is really important for the salt you're cooking with. Some sea salt in products is not a problem when it's below 500 milligrams of total sodium per serving. So yeah, hope that's helpful. Let's see. Okay, picking and choosing, you guys. Lots of really good questions. I won't be able to get to all of these. That breaks my heart, but I'm going to do a bunch of these. Let's see. So I'm looking for related ones for starters. Lots more health practitioners jumping on. Welcome, welcome. Stay tuned, you guys. I've got a lot of training that's coming up for healthcare practitioners. If that's you, be sure that you are getting our newsletter at drchristiansen.com. Let us know you are a healthcare practitioner, and you will be in the loop. We've got a lot of fun stuff coming up for later on this year. Oh, okay. I'm just trying to pick and choose, you guys. This is tricky. Well, this is kind of straightforward. Claire, hi, having all hyper symptoms plus a dose 100 and up to 116 at times. Oh, pulse. I'm so sorry. Pulse. So your heart's racing. I got it. Losing weight, have hand tremors, don't sleep well, either weak at night. TSH levels 0.04. Yeah. I'm sorry. I should have. I don't get the. I can totally do that, Claire. Claire, I don't know if you're on medication and this is a high amount from the medication, or if this is something that has not been diagnosed. You didn't say anything about medication, so I'll talk as if you're not. We think this is clearly hyperthyroidism, and if someone's not on medication, the most common cause by far is Graves' disease. That's about 80% of the time in a situation like this. The remaining 15 to 18% or more is toxic nodular goiter, but one of those two are the most likely scenarios. And Claire, this is an important thing. I do see a lot of situations where doctors will say, oh, it's not that bad, we can just watch this. It's a big thing, and you're having your health affected by this. So please do seek out some care and make sense of this. I'll talk a bit more about this on Wednesday as well. Anyone who's in Arizona, California, Oregon, Washington, Montana, and Utah. Those are the 6 states. My doctors are licensed in those states. We can help out directly, and we can also help make sense in terms of diagnosing and managing hyperthyroidism. So integrative healthcare, take a look. You can do a talk to a doc. You can click a button and talk to a doc for a couple minutes and see if this is someone you'd want to work with. And they can also help give you feedback as to whether or not your condition is one that we can help with. So a really easy way to go to check things out that way. Okay. Okay, so here's another related one. I'm, again, trying to get related ones as much as possible. So what about fluoride effects on iodine from Melanie? So Melanie, there's an argument out there saying that everyone needs more iodine because we're toxic with fluoride. And I understand the logic. The thought is that fluoride will block iodine's absorption. It'll block the receptor, the sodium iodide symporter. And it's true, but it's true for a specific dosage level. So if we go back to the prior to the 1940s, before there was medications to slow the thyroid, fluoride itself was used to treat hyperthyroidism. And it took doses upwards of about 30 to 50 milligrams per day as a starting dose. And fluoride can cause hypothyroid side effects. But the question is, dosages matter. And this is something that kind of makes me nuts because there's times where people get concerned about things and they disregard the idea of dosage. So if fluoride does that, does every dosage of fluoride do that? Fluoride's in kale, right? And fluoride's in plums, and fluoride's in tea, and fluoride's in a lot of foods that are healthy foods. So does every amount of fluoride slow your thyroid? Can you never eat kale or plums or strawberries or, spinach again because they have fluoride in them? No, of course not. So there is a threshold that matters, and it seems to be somewhere around maybe 10 milligrams per day. They've done some big studies, even areas that have fluoridated water. Not a fan of fluoridated water. I think there are some drawbacks to it, but does it slow the thyroid function? No. Now, there's municipal fluoridated water, which where little is put there on purpose. Then there's some areas that geologically have ridiculous amounts of fluoride. It's just in the rocks, it's in the underground. And the unprocessed water, which is contaminated with probably other stuff too, has contaminated toxic amounts of fluoride. And there's been a few pockets of China like that. And in those cases, there have been changes in thyroid levels in some children that relate to the fluoride in the water. But it's not the same as municipal fluoride. It's not the amounts that we have in dental applications, and it's not the amount you're going to get in spinach or plums or normal foods. So yeah, no worries apart from just like megadose fluoride supplements, which aren't really common things. Lots of good questions, you guys. Let me grab a couple more of these here. So here's one. 6 months after going off hormone replacement therapy, I developed thyroid. Developed hypothyroidism something? I think I even saw a follow-up comment about that. Developed hypothyroid. I don't like spell check. That's okay. I'm with you. Can being removed from hormone replacement, can one develop thyroid problem? No. So yeah, there's a relationship there, but not so much that way. So hormone replacement, also oral contraceptives, also just normal circulating amounts of estrogen, they do compete with your thyroid hormones. And what they do is they cause more of an amount of a protein called thyroid binding globulin. So the more of that is in your bloodstream, the more thyroid hormones are less active, the less that they're really doing in your system. So if a woman is, let's say, marginal on her thyroid function and she starts hormone replacement, in those cases, that may be enough to make it just push over the edge. And now she could be hypothyroid. A really common scenario is more so the opposite, to where someone who's on thyroid treatment goes on hormones and now needs to have their dose increased. And then the opposite happens as well. If someone goes off of hormone replacement and they're on thyroid medicine, they commonly need less. And this shouldn't surprise doctors, it's predictable. So if you went off of hormones and your thyroid slowed down, it probably wasn't related. It probably was going to happen anyway. And yeah, take a look at the thyroid reset diet. I talk a lot about why that happens. And the exciting story is that the majority of the times it can be fully reversed. And by majority, I mean 60 to 80% of the time. And in the cases where it can't be fully reversed, a really good chunk of those, it can get an awful lot better. And your own output matters a lot. I used to think that if you were taking a medication, like taking a natural hormone blend, and it gave you certain blood levels, that you were the same as someone else who wasn't taking hormones but made that by themselves. But I don't believe that anymore. There's been more data mounting showing that what your body does, even if it's the same thing, making it is not the same as taking it. We had one big study that came out of Korea, and they looked at 500,000 people on thyroid medication, and they really carefully matched them with a larger group of 1,500,000 people not on thyroid medication. By matched, I mean they got the same ages, the same gender proportions, the same percent that had high blood pressure, the same percent that had diabetes, and so on and so on. So they all should have had about the same relative risks for the group. But those on treatment had more, like 30 to 40% more early death. So this is the thing. We want your body to work better. It's not just handy to have fewer pills. If your body can make it completely or by some degree, that's a healthier outcome, even if it's the same levels. So yes, as much as your body can do, the better. All right, let's grab a couple more questions here. I saw one further back. This is a straightforward one from Shiva. How much time does it take for levothyroxine to reach peak levels? So Shiva, yeah, so levothyroxine is T4 and it absorbs and has a half-life entering the bloodstream. Now, peak levels, there's two different ways of thinking about that. There's the peak in the bloodstream and there's the peak effects upon the body's metabolic function. So the latter is something that we do not see based upon blood tests. The latter is something that's based more so on how quickly we eliminate the medication. So that one is much slower. That's on the order of several weeks even. So peak effects are taking the course over weeks. Now, peak serum levels, peak blood levels, that's going to vary between somewhere about 3 to 12 hours for that peak blood level. And I've got some graphs that I've shown the pharmacokinetics of this before. There's a lot of variation from person to person, and even within the same individual at separate times. So it's somewhere in there. And Shiva, for the reason that it's so variable, that's why I discourage testing after you take your medication, because you're going to be higher in the several hours afterward, but no one knows exactly by how much. It's completely random. And the same thing is true of T3. So if you take your medicine before your tests are done, and you measure T3 and T4, you really can't make sense of that because there's so many ways it can be randomly different. So yes, there's a peak somewhere in that time frame, but yours is not always going to be at the same time within that window. Here's another good question. I think I saw a version of that as well. Is heme iron supplements good or non-heme? Can you please tell me about the role of hepcidin while taking iron supplements? Yes, so great question. I put a ton of thought into this when I formulated our new mixture called Easy Iron. I'm going to put a link up for you guys because I'm really proud of this stuff. So this is a version of iron that is much better absorbed and much lower in rates of side effects. And you'd think, I don't know, I'm surprised that there weren't more examples of this that were made already, because all the ingredients in that have been really well documented to do just that. Arguably, we could see as much as 6 to 7 times total absorption per milligram of iron, and also almost no side effects for most people with this blend. And I thought a lot about heme versus non-heme. So now, normally heme versus non-heme for iron, this is a discussion about iron in food first and foremost. So heme iron comes from blood, non-heme iron comes from plants. So many versions of elemental iron are actually neither. They don't fall under that category. They're not one or the other. However, there are some iron supplements that are heme iron. They are the same as iron that's derived from blood. Now, in the human body, there's carrier proteins that selectively absorb more or less iron based on how much we need. They don't always work perfectly. In the case of hemochromatosis, they absorb more than is needed and that causes an iron buildup. But normally they pull in more when you need more and less when you need less. And there's a range. We can get somewhere between about like 20 to 50% of heme iron and somewhere around 2 to 30% of non-heme iron. So the big difference there is the fact that with non-heme iron, we can absorb less when we want less. It doesn't really build up too much in our bodies. That's not true of heme iron. But yeah, this is still talking about iron in food. So heme iron in supplements, there have been some made, and I did consider heme as an iron source early along. The drawback is that it is much less concentrated, so you need to take much higher amounts of it, and it's also much less cost effective. So a therapeutic day's dose for a heme iron product is typically 10 or 12 times the cost per milligram of a regular iron supplement. And again, regular iron supplements are not non-heme. They're simply unrelated. They don't fit under that category. So yes, so I chose ferrous fumarate because that's a type of iron that's found naturally occurring in many foods. It's got a very good safety profile, and it's also more concentrated. So in Easy Iron, we've got 100 milligrams of iron, bioavailable iron per capsule. By adding a therapeutic amount of vitamin C within the capsule, and also by adding citric acid and piperine within the capsule, that's what raises the absorption so greatly. And then also we see a corresponding decrease in those side effects. So good thing. We'll get one or two more questions here, you guys. These are really good ones. Lexi's asking, what happens if one is given thyroid replacement, specifically NDT, and they didn't really need it, were subclinical? Can it cause the thyroid to stop functioning? Well, Lexi, so it can, but does it always? Not always. Now, the longer someone is taking it and the more excessive their dosage is, the more likely that's a problem. So, Lexi, we know someone's dose is excessive if it's way above what their body would make. And Lexi, if you want to even put in some, I'll watch for this, if you want to put some specific numbers about body size for someone that we might be asking about, I can give feedback on how much that would be. You know, a ballpark idea is that a woman who's roughly 100 pounds, her body would make in the ballpark of 1 grain of natural thyroid. If she were 150 pounds, it would be in the ballpark of 1.5 grains. Now, that differs whether or not she's menstruating or on hormones or a lot of other factors, but those are some ballpark ideas. So if you're taking way more than your body needs, it's more likely you're making less. And then also, Lexi, if you've had ultrasounds, there are times where someone can see if the gland is like completely shrunken and small. So if you've been on therapy for fewer than a decade, fewer than 10 years, and you've not had your TSH pushed down the whole time, and you've not been on a dose way above what your body's needs are, then you wouldn't necessarily have your thyroid be suppressed. But a lot of the same things I was saying earlier to the gal who was asking about taking a lot of iodine, those same things apply, getting your iodine lower first and foremost. Okay. Okay, so here we go. 105 pounds, TSH on 1 grain was near 1.0. So yeah, in that case, your dose was more close to what your body's needs were. You may or may not have been making too much, but you weren't on a suppressive dose anyway. So if you want to mention the duration, I can certainly give feedback on that. So I'll get one or two more related questions. Carol's asking, does cooking with cast iron increase our iron? Carol, it can. And in cases of those that have too much iron absorption, that can be a problem. That's rather rare. And it also depends upon what kind of food you're making. So the ultimate example would be like a really old family heirloom cast iron pot, and you're cooking a marinara in it. So something acidic, basically, or something that has a fair amount of citrus or vinegar, like a prolonged boil. So that can pull some iron inside the food itself. And again, normally it's not a problem, but if somebody had iron overload, you wouldn't want to use that. You wouldn't want to cook for them with that. Okay. Lexi, about 4 years on NDT. Yeah, Lexi, barring a really shrunken thyroid on ultrasound, you wouldn't necessarily be stuck on that long term. So, yeah. Oh boy. There's some really good questions. Let me get one quick one here. Sean has so many good questions, and I'm going to get one of these here for us. If one is required to maintain a ketogenic for a rare neurologic disease, how will this low carb but isochloric way of eating impact thyroid function and or the accuracy of lab markers? So if one's got a rare disease and is doing a ketogenic for that, what's the likelihood that we have good clinical trials on their thyroid function in that exact situation? Of course, we don't know, right? So what we know about thyroid disease and ketogenic diets, we know this really from kids that were put on ketogenic diets for epilepsy. And kids don't really get much for thyroid disease. So in adults of many demographics, thyroid disease can be as prevalent as 10%. But in kids, most pediatric ages, it's rarer than 1 in 1,200. It's quite rare. When kids are put on ketogenic diets for epilepsy, the rate of thyroid disease gets very close to 30%, like 27 to 30%. And many of them actually need thyroid replacement. Now, we're not sure if they're going to have lasting problems or not, but we do know that their thyroid changes. And we know some mechanisms that explain that. When insulin levels are too low, we know that that can inhibit the body from activating thyroid hormone and also from secreting thyroid hormone. So are the benefits of the treatment greater than what the risk could be to the thyroid? That's really going to be a judgment call between yourself and your clinician, but impossible. There's really been no data on anything that narrow, other than we know it could be a risk. Okay, let's see. So here's one that's could be relevant for many. Why can an individual continue to lower thyroid antibodies, but TSH remains elevated, despite being vigilant about avoiding iodine and following your reset diet religiously? So the question is kind of about, what do antibodies have to do with TSH levels? And the answer is not always a lot. So the antibodies themselves, they loosely predict the progression of thyroid disease, but it's very loosely. So if someone that has very high antibodies, we've got strong numbers from those who do not yet have disease, but they're illustrative. If someone doesn't have thyroid disease, both their antibodies are very high, they've got about a 2% annual risk of having their thyroid slow down. Now, if their antibodies are low, that's more like about a 0.9% annual risk. So it's not that crazy different. So if they're lowering that's a positive thing for sure. But other factors that affect the TSH being elevated, and the other big question is the TSH being elevated. if that does correlate with symptoms or if it's going to benefit from medications. Sometimes that's a function of how medications are dosed, how they're being withdrawn, how they're being tapered. But that's a great scenario to work with someone who is familiar with tapering and really monitoring those things closely. And then we think too about if someone's on a low iodine diet and their thyroid is not responding or seeming not to respond, then the question is really just about if there is some source of iodine they're missing or if they need more time on that. We had a gal earlier, just today, who mentioned that she was on a very high dose of iodine for a while. She could be excreting a lot of iodine for 6, 12 months. So that can be a scenario if someone really is following the diet closely and their serum levels are not improving, that can be a time where it's worth testing. And that's worth a urinary iodine to creatinine ratio test. If there's a lot of iodine coming out, then you wouldn't yet have reached a place at where the low iodine would be helpful. It just takes more time on that. Or it can mean there's still some iodine coming into your system. So there's just a couple thoughts on that. And yeah. Okay, let's grab one more here. This is tricky, you guys. Which question should I get? There's so many good ones here. Let's see. Okay, maybe more than one because there's so many good questions. Let's go. Here's a quick, easy one. Where did it go? Here we go. Living Peace. Doc called today, wants to lower NP thyroid meds. What are the signs meds need to be lowered? So, need to be lowered signs. Well, for many people, they could be on a dose that's higher than is best for their bodies, and they may not have signs, they may not have side effects from that. So, signs, we normally mean symptoms, things that they're aware of. The first change to occur is once TSH dips below range, and that's your brain saying, this is too much thyroid hormone for me. Now, if someone's been on treatment for a while already, that's generally a positive thing. It generally means that your body is responding better to it and or you're making more by yourself. But the earliest change would be TSH getting too low. If one is far above dosage, a later change can also include elevations of T4 and finally elevations of T3. Those don't happen all that commonly. They're more common if someone's been on a high dose for far too long, and they've been simply tested after they took their pill. That's a more common reason for T3 and T4 to both be high. That's a later stage of hyperthyroidism. So usually the first step is the TSH gets below range or it gets all the way down. That's what would make someone think about lowering the dose. In many cases, there can be side effects that can include difficult weight loss, racing heart, anxiety, sleep disturbances, tremors. They're not always there, however. So, yeah. Okay, so this is related to that one. And I've got to get this question, Jennifer. I've got an image I want to share with you too. This is so important. So why would a person's pituitary lower TSH when free T3 and free T4 are low? That's a really good question. And actually, Jennifer, I just did a brand new podcast episode that was a super, super deep dive into this. Now, where did I stick that image? I had a perfect image about this. Yes, I think I put it here. Oh, no, not there. I'm not going to flounder around too long, but I really want to find this for you guys because it's really helpful. Okay, maybe it's in here. Oh, it's right there still. Is that it? Is that it? No. There it is. Ha, got it. Okay. So take me just 1 second, and I've got to go over here and change something else, and then this will show up momentarily. Okay, so thank you for your patience. It's here, and now I've got to get it to go over there where you all can see it. All right, so now I got to find it again. And here it is. Okay, so let me get here and images, drag and drop. Ha, okay. So if I did this right, yep, there we go. So now I'll get this image shared with you all on Instagram afterward, but this should now be visible for those who are on Facebook and YouTube Live. So this is how free T3 and free T4 relate to TSH levels. And Jennifer, this is a question that really confounds so many doctors, and it's often behind people being over-medicated. doctors often assume that people need to have high T3 and high T4. And to do that, they almost always end up with low levels of TSH, like really low. But on this chart, what happens is there's a point at where the TSH is getting lower. So the TSH is the blue line. There's a blue line that represents it. And as it moves over to the right, it gets lower and lower. You can see as it goes to the right, there's a point where the T3, which is yellow, and the T4, which is orange, they drop as the TSH is dropping. And this is not a pituitary defect. This is a function of the peripheral metabolism. So the pituitary controls the TSH. It doesn't directly control the T3 and T4. All the rest of the body does, including the hypothalamus, the liver, the kidneys, the deiodinase enzymes. So as the body is getting too much thyroid hormone, all the mechanisms that eliminate thyroid hormone get ramped up. And that's where we can see this window where the TSH is creeping down and the free hormones are also creeping down. So this is no longer the pituitary doesn't control the free hormones, it just controls the TSH. But as it's telling the thyroid to work less by lowering the TSH, the body is eliminating thyroid hormone. So it's very common to see low levels of T3 and T4 when the TSH is too low. Now, in that situation, if someone were to add ridiculous amounts of thyroid hormone on top of it, there would eventually be a point at where the body couldn't eliminate those hormones anymore. It couldn't keep up with that elimination of those hormones. And in that situation, eventually the free hormones would elevate. They would get very high. But before that happens, they often dip down. So this is a really good question. And again, it totally confuses doctors. I hear doctors all the time that will say they think their patient's pituitary gland is not working right. No, it's working just fine. The pituitary doesn't control the T3 and T4. It controls just the TSH. So when the TSH is low and the body has low T3 and T4, that's because the body is fighting those thyroid hormones. Now, there are some rare cases, of course, where the pituitary doesn't work right, but that looks quite different. That looks like no TSH and almost no T3 and T4, like completely flatlined. And that's not occurring by itself. It's occurring along with complete flatlining of like everything else in the whole endocrine system. So yeah, great question. Sean, this is a chart that I don't have a link for. I've used this in my talks. This is one that I compiled by averaging about 150 different thyroid scores together and making a weighted average out of those. So yeah, not published, not available. All right. Good to see you guys. Hope you have a great rest of your evening. And yes, this coming Wednesday is World Thyroid Day. I'm going to drop this link up here again. So those who are trying to get their full recovery in place, one of the most important parts is having a team that can really support you. Having a team that believes that recovery is possible, having one that knows how that can happen for you, and having the right people in place for that team. And I'll talk all about how to make that happen on Wednesday night. In the meantime, take great care, and we'll see you real soon. Bye-bye.